Good morning, everybody. As we all know, posterior polar cataract always remains an enigma to every cataract surgeon due to high chances of PCR. Here, we would like to discuss the strategies and modification of techniques to prevent PCR in a posterior polar cataract. We would also like to compare our rates of PCR with other existing studies.
नहीं वो वाला टाइमर भी एक साथ स्टार्ट होना चाहिए ना।
नहीं वो तो हो सकता है।
एक बार रीसेट कर दीजिए।
स्लाइड आगे भी नहीं बढ़ रहा है।
नहीं बढ़ रहा है।
नहीं बढ़ रहा है।
स्लाइड आगे नहीं जा रहा है।
स्लाइड आगे नहीं बढ़ रहा है। So in our technique, we preferred approach is usually a temporal clear corneal incision with a 2.2 millimeter square incision, which helps to maintain a closed chamber throughout the surgery. We avoid overfilling the antechamber with viscoelastics. Sometimes a cohesive OVD could be used for capsular access. The size of the capsular access is usually more or equal to 5 millimeter to prevent backflow of the fluid during hydrodelineation. In case of a PCR, it is easier to dial out the nucleus. Cortical cleaving hydrodissection is avoided as it may build up hydraulic pressure rapidly and cause a blowout of the PC. Hydrodelineation separates the endonucleus from the epinucleus, which acts as a mechanical cushion, separating the nucleus from the posterior capsule and preventing transmission of mechanical and fluidic forces to the weakest part of the capsule. Vigorous decompression and nuclear rotation is avoided. Vasavada and Rajatal's technique is of inside-out hydrodelineation is one of the safest method. A central trench is first sculpted. A right angle cannula is used to direct fluid perpendicular to the lens fibers in the desired plane through both the walls of the trench. A golden ring within the lens mandates successful hydrodelineation. It prevents inadvertent subcapsular injection and overcomes the difficulty of introducing the cannula to a significant depth in a dense cataract. We have adopted the similar technique and added viscodissection and viscopeeling of the posterior polar plaque. Nucleus removal is done with a low parameters with a slow motion phaco, power less than 60% with a bottle height of 50 to 70 centimeter, aspiration of 15 to 25 ml and vacuum of 30 to 90 millimeter is considered to be safe. Nucleus removal is done within the cushion of the epinucleus to reduce the risk of posterior capsular rupture, prevent the shallowing of the anterior chamber by use of dispersive viscoelastic through the side ports. Nuclear rotation and wide separation is avoided. Epinucleus is aspirated layer by layer. The thin layer of cortex adherent to the capsule is left behind. Central area attached until the we leave it until the last stage of cortical aspiration is done. The posterior layer along with the plaque is then visco-peeled and aspirated. We have a small clipping. After the capsular access is done, the central trench is made and the desired plane. The central part of the trench is slightly deeper as compared to the periphery. Once the trench is done at the desired depth, the loose cortex is aspirated out. Viscoelastic is injected before removing of the phaco probe. A right angle cannula is now introduced through the wall of the trench to the desired plane and hydrodelineation is performed. It is repeated through the second on this wall. Once hydrodelineation is completed, phacoemulsification is performed. Viscoelastic is injected through the trench below the capsule to lift up the nuclear fragment, which makes phacoemulsification easier. Cortical aspiration is done with a low bottle height. Pulling of cortex is avoided. Tangential movements are safer. And PC polishing should be avoided due to possible presence of a fragile capsule. The posterior polar plaque removal is done at the last stage of cortical aspiration. It could be removed by viscodissection and aspirated by the phaco tip. Viscodissection protects the posterior capsule. A dispersive OVD is injected between the epinucleus and the posterior capsule that generates space and cordons of the posterior polar plaque. A posterior capsulorhexis can be done in case of an adherent plaque, or an ND-YAG laser could be planned later. We avoid polishing the posterior capsule. Loose cells are irrigated gently with a 1 cc syringe. 18 eyes in our study were considered with posterior polar cataract. Phacoemulsification done by a single surgeon. Rest of the parameters remained the same. 17 eyes were successfully managed with no PCR. 1 incidence of PCR occurred during plaque removal, which was managed well. 5.5% incidence of PCR in our small group of studies. When we compared it with other studies, earlier studies reported incidence of PCR ranging from 26% to 36%. With improved technologies and modified techniques, the incidence of PCR reduced to 6 to 7%. The incidence of PCR in our study is 5.5%, which is comparable to the above studies. To conclude, we have adopted Vasavada and Raj et al.'s technique of inside-out hydrodelineation, which proved to be a safe method in our hands. Our modification of viscopeeling of the posterior plaque further helped in reducing the risk of posterior capsular rent. Thank you.
Thank you.